بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Peace upon all of you everywhere. And I'd like to welcome all of you, my dear guest speaker, Dr. Steve Arshinoff, and my dear professors, the panelists, Dr. Mohammed Al-Moddather and Dr. Mohammed Khedr, on the grand round, the Hossam Ziada grand round Zoom meeting room. And you are going to talk today about one of the very, very important issue for the Phaco surgeons who are dealing and using the Phaco machines. And it's very important for all of us to know the device that we are dealing with. Excuse me. I'm sharing my screen now. So we are honored today to have our honorable guest speaker, Professor Steve Arshinoff, Professor of Ophthalmology, Toronto University, Canada, the President of the International Society of the Immediate Sequential Bilateral Phaco Surgeons. And because of being the president of this, the highly debated item or issue worldwide, we will take this opportunity after covering the Phacodynamics to talk about the immediate bilateral Phaco with international standards and the conflicts. Also, I'd like to welcome the dear panelist, Professor Mohammed Khedr, Professor of Ophthalmology at Al-Azhar University, and Professor Mohammed Al-Moddather, Professor of Ophthalmology and Chairman of the Ophthalmology Department, Acute Branch at Al-Azhar University. And I'd like to welcome all of the audience who are attending this meeting and also on the live on the Facebook page of Ziada Academy. Thank you very much. And I may ask Professor Steve Arshinoff, the great scientist in the field of the cataract, refractive, and the cornea surgeries, and also he's involved in the settings of the Alcon-related machines, Infiniti and Centurion. And please, Dr. Steve, start sharing your screen. I will stop my share. Yes, sir, you are allowed now to share a screen. Yeah, okay.
Okay, you can see my screen?
Yes.
Okay, so thank you very much for all the accolades, some of which perhaps are true. It's always nice to hear that. Last time we got together, or the time before, I gave a talk on some basics of how Phaco machines work. And I was asked to enhance upon that and explain it in more detail. So the reason I have this funny diagram in front is because starting in about, I don't know, the late 90s or 2000, Alcon asked me if I would go to California about once a year and meet with the engineers and talk about how they were looking at designing either improvements to the Infiniti and then after to the Centurion machine, and to contribute to how it's made and to choose among the various choices they had and how it's designed. It's actually a very fun experience because you realize how the engineers know a lot more about these things than we do. We always think we're so smart as doctors. Turns out they know much more. So I'll give you a picture here. This is an Alcon Intrepid. I don't know which machines are most common in Egypt. This one was a version that came out about 2009, 2010. And when we look at the machine, you want to look at it as a surgeon in what can I adjust, what can I play with, can I make it better than the engineer makes it? The problem the engineers have is they take these machines and they give them out to everybody. They have to cater to everybody. So when they cater to everybody, most people that get the machines don't really know very much about physics or about how the machine should work or how to set it. And so they set it on a setting that they think will be reasonably safe and people won't cause damage. And if it takes you a little bit longer for your surgery, well, that's your problem. But they try to make it at least work well for everybody and be very safe to use. So they do things like on the bottom here, they usually have a whole bunch of different buttons you can choose. And as you see, I've got rid of all of them except for CHOP and Cortex. And the reason I did was my philosophy of how machines should work is that the machine should not work by you constantly pushing buttons to change how the machine works. The machine should work like an automatic, expensive car, where you basically push the gas and the computer on the machine adjusts the way the machine can work the best to achieve what you want to by going faster, or up a hill or down a hill or whatever. And so there's a few things that I said that I'll talk about. I'll talk about the custom pulse and how I set this to what I call continuously variable pulse, that as my pedal goes down from 0 to 90 in power, that the time at which the Phaco is on also decreases. So the power goes up and the time goes down, and I'll explain to you why. Then you get a little gap to make sure that the tip doesn't overheat every once in a while, to just leave it off for a brief interval that the surgeon can't hear because it's just 20 milliseconds. And this has to do with the axial pulses, and this has to do with the torsional pulses. And here you can see I left the on time stable because torsional doesn't have the effect of pushing the nucleus away, which an axial pulse does. Then you can change the dynamic rise. This tells you how quickly the vacuum will build, and we'll get into discussing that when I discuss how the whole thing works and what the vacuum means. And this is an IP. This is a device that Alcon put on their machines to get around paying me for doing this. And what this does is it automatically, when suppose you set the vacuum limit at 310, if it gets to, let's say, 290, this will bleed it out and allow it to go back to lower vacuum again and to give a shot of axial pulses. So that way you don't get the tip being caught on a piece that occludes it and then overheats. It works very efficiently. So that's just a picture of a machine, and then I'll discuss some of the things about what we do with the machines and how we make them better. So the first thing you have to do is, before you make anything, is decide what you want to do. So until you decide what you want, it's very hard for a company to do it for you. So I told her I want my machine to work completely automatically, and just I'm going to push the pedal like I would a gas pedal, and then the machine should adjust all electrons itself. So I want the Phaco to quickly eat up the cataract, and that sounds like a very simple thing to do. You just put more power, but it's not true, because if you have a dense piece of lens and you hit it very hard with a Phaco, what it does is the Phaco buries into it, it seals around the tip, and then it heats up. The only way it's going to eat into a cataract is if it keeps changing the pulses. If it keeps changing how much pulse it has and how much time in between, then it will make the lens rotate. And then it will work better. So this is not simplistic. And you also don't want to place any stress on the capsule. So you don't want to do things like sculpting, for example, because sculpting pushes the lens against the capsule. And what you're going to do is you're going to cause the patients to come back to you 4 years later or 5 years later with dislocated lenses, with the capsular bag dislocated as well, because you broke a bunch of zonules. And you also, of course, don't want to aspirate vitreous. So the question is, how can you make a machine to do this? And what should the surgeon know about the machine to make us not do that? This is the one equation I want you to learn. And this is the most important equation in how Phaco machines work. And we're going to start off really, really simplistically, and then I'll tell you why everything I said is only a vague approximation. So everything that flows, whether electricity, water down a stream, or the water in your Phaco machine, goes along Ohm's law, which is the force E is equal to I, the flow, times R, the resistance. And you say, well, that's really simple. It should be very easy to build a Phaco machine. Well, it is simple as long as everything is in an ideal space. And as you learned in physics in high school and university, those spaces are referred to as black boxes, and black boxes don't exist. But in reality, there's always problems. So the force, this equation means, is equal to the flow times the resistance. That sounds perfectly reasonable. So it's the same as saying that the pressure is equal to the force divided by the area, which is from Newton. It's just turned around a bit. Okay, fair enough. So then what is are each of these in terms of Phaco machine? Well, we all think that the force is the vacuum we set on our machine, but it's not true, because the force is also the bottle height. But because the bottle height, the water pushes and the vacuum pulls. You can actually, there was some videos made by Jack Singer in the mid-90s showing how you could do zero vacuum Phaco. Well, you can if you put the bottle high enough, because it doesn't matter if you push or pull, force is force. And if you have a potential leak going into the Phaco handpiece and a high bottle, it's going to push the contents of the AC into the Phaco tip. And now Alcon has changed this from having bottle height to setting the intraocular pressure. And the simple question is, why did they do that? Well, the problem with having bottle height is many, many surgeons have incisions that leak. And so bottle height can't control for the leakage. If you make tight incisions and your bottle height is 100, the pressure in the eye will be about 75. But if you make loose incisions and they leak and the bottle height is 100, the pressure might be 30 or 40. So the surgeon's response is to just raise the bottle. What the surgeon's response should be is to learn to make better incisions. But Alcon can't tell you that, but they can tell you that they can set the machine so that it will pump in more pressure if you make leaky incisions. And that's essentially what the Centurion does. It controls the pressure. And so if the incisions leak, it just pumps in more fluid. So is that good or bad? Well, it's good and bad. It's good because it maintains a stable pressure in the eye, but it's bad because it increases the flow rate through the anterior chamber. And that means you're going to wash off the viscoelastic and wash off endothelial cells. So what you learn from this is that making leaky incisions is a bad idea. It's going to cause more damage in your surgery. So you want to make very tight incisions. So now we started off by saying, well, E is equal to IR. And now we haven't even got past E. We realize there are many, many things that contribute to it. So if you remember this equation and you remember that, okay, list of force is the vacuum we set, plus it's the bottle height, and then the pressure, and that depends upon the incisions, you start to understand what we're doing when we do surgery and all the complexities that matter from a good surgeon to a not very good surgeon. Often they aren't that difficult. All you have to do is make a tight incision and you've basically controlled the force. But that, not just the main incision, but the side port too. If you make a sloppy side port incision, it leaks just as bad as making a sloppy main incision. So then we have the flow. Well, what is the flow? The flow is the outflow. All right, the force is the pressure, the vacuum force we set where it can build to a certain point. And the flow is, we thought, well, it's the aspiration flow rate, but it's not. It's the aspiration flow rate plus the wound leakage. And the company that makes your machine for you has zero control over the wound leakage. The wound leakage is a function of how good your incisions are. That's why, again, they went back and tried to control the pressure. All right. So some people who first use Centurions don't like them because their wounds leak too much and they can't get good control of the pressure. So instead of them understanding that the problem is their surgery, they go and they blame Alcon for making the machine that way because they can't get what they had before and they could just keep raising the bottle. But if you understand that the flow is not just the flow rate you have in your machine, but also how much leaks out, you'll realize how critical the incisions are. And then we have resistance. Okay, so, well, we're taught that it's the density of the lens or some function of density of the lens, which it is. So it's the aspirate viscosity divided by the area of the port. But the problem with that is, that's not all it is. It's also the tubing resistance. So you may have noticed when you bought a new Phaco machine or when you put together the cassette on the Phaco you use, that all the tubings are a little bit annoying.